So good morning. I'm really happy to moderate this opening session of AI for Health. So until now, we had AI tools that were analyzing and recommending, but always the decision was taken by a human. When you think about agent AI, they go further. Imagine an AI that does not just flag a patient with a risk of decompensation, but actually initiate the appropriate protocol, coordinate the care team, and takes track of the progress. This autonomous ability to take action opens a new era for truly improving patients' outcome. Thank you for joining us to discuss about this transformative challenge. And we have the chance to be joined by 4 leaders who shape the future of healthcare across industry, research, and care delivery. So I will let you briefly introduce yourself. So Emma Charles, please.
Thank you and welcome everybody. I'm delighted to be here. I represent Bristol Squibb, a pharmaceutical company dedicated to research, especially in oncology, hematology, cardiovascular, and neuroscience, and I lead Europe.
Thank you for being here. Professor Jan Abbs.
Thank you very much, Stephanie. It's fantastic to be here. So for the last 7 years, I've been the chief executive of the largest health system in the UK, but also have focused on bringing some of these new tools in technology to the difficult equations of healthcare. In fact, I've just stepped down from the CEO role to focus on how do we implement these tools now.
Thank you for being here. Mathilda Ström for Bioptimus.
Hi, so my name is Mathilda Ström. I am the Chief Operating Officer of a company called Bioptimus. You may not have heard of us yet, but we are building the world's first multi-scale, multimodal foundation model for biology. What does this mean? Think of in the most simple terms, an open AI, but with using biological data as the input rather than text and language. In my previous life, I was also an entrepreneur in another space, which was in telemedicine in Africa, Asia, and Latin America, so have also seen the front lines of delivering healthcare to people who are underserved.
Thank you very much. And our last panelist, Arafat Malika from our partner AWS.
Thank you very much. Arafat Malika, thank you to the audience and to my fellow panelists. Arafat Malika, I'm a global sales leader at Amazon Web Services, which means I have the overall responsibility for some of our largest and most strategic customers. And I lead AWS Healthcare and Life Sciences business development activities across EMEA and APAC, which gives me good visibility on the trends at the intersection of healthcare and technology and AI.
Thank you very much. So let's start with the first question for you, Emma. Can you give us an example where the impact of AI agent is already or will be very visible for the patients, please?
This is a very important question, and above all for physicians, for the medical community, and for patients. And I'm particularly excited about how AI is transforming and will transform the way diagnostic is made for patients. When you deal with pathology like oncology, where you know that it's very important to diagnose very early on to have a better outcome for the patient, AI is going to be a support and a very important tool through machine learning in identifying a diagnostic very early, but also misdiagnostic anomalies that the doctors sometimes do not see with human eyes. So that's important. I would like to bring an example of a partnership that BMS is doing with a company called CareBot. We have experimented with this company a search for early diagnosis in lung cancer. This company is developing an AI, machine learning, and power to look at radiography and X-ray for chest. And so we are partnering with oncologists and radiologists to be able to go systematically to every X-ray chest of every patient. And thanks to that, we are able to identify in some patients that were not treated for cancer or they were not coming for a diagnostic in cancer, we are able to say, well, there is a very small lesion and we need to do additional additional tools and additional diagnostic to see if there is a real cancer here. But the beauty of this is we are able to generate early diagnostic, and this is better for patient and for the long-term survival. We are so happy with this experimentation that we are expanding this to many accounts in 6 different countries of Europe. And we were able also to present a poster at ESMO AI, which is an oncology convention in Europe this month.
Great. Professor Jan adds, it's not only about diagnosis, but the everyday life of medical doctor will change thanks to AI agents. Can you tell us what you expect?
Yeah, thanks, Stephanie. 2 points on this. The first is I think this audience would probably agree. The fundamental equations of healthcare delivery, where supply to the greatest extent in high GDP countries has matched demand, those equations don't work anymore, because the main factors of supply, which are people times money, it's no longer possible to sustain those 2 resources. And actually, we're probably going to run out of people before we run out of money. And if those equations fracture, then it starts to impair the fabric of society. So this is really important now, and I think all clinicians are feeling this fragmentation of the fabric. The question, I think, for us is all health systems were designed for constraints, but agentic gives us the opportunity of superabundance. So how would we redesign a health system based on a superabundant model? I think that's an interesting question.
Thank you. So all the solutions that are required for developing AI agents can be done on, with the support of AWS. Arafat, tell us more about what are the main trends you see across this industry.
Thank you. We are indeed seeing increased focus on agentic AI across our global life sciences customers, with the objective of driving speed, automation, and enabling the workforce to focus on high value-added activities. And we are seeing that shift across the value chain, from drug discovery to clinical automation, to clinical development, to commercial operations. So for instance, when it comes to drug discovery, we are seeing our customers deploy AI agents to augment scientists. These agents are able to automate complex research workflows and break down research problems into steps, where every step is not predetermined, rather defined on the fly, based on the information the agent would have found in the prior step. And by connecting these agents to internal data stores and external data sources, we are seeing our customers substantially accelerate target and lead identification processes. We are seeing a similar trend in clinical development, where we see AI agents deployed to orchestrate clinical data ingestion, transformation, harmonization, and integration across multiple data sources, whether it's EDCs, labs, imaging, real-world data, thus breaking the traditional sequential handoffs that used to take weeks in the context of clinical trials. We are seeing agents deployed to optimize clinical protocols, analyzing historical data, real-world data, thus reducing the protocol development and optimization timeline by up to 75%. We are seeing them involved in patient recruitment through intelligent site selection, thus reducing the underlying timeline by 50%. And when it comes to commercial operations, AI agents are deployed across 2 fronts. One is commercial insights, democratization, and the second one is omni-channel automation. For instance, we are seeing medical and legal review timelines reduced by up to 60%, with AI agents being able to tag content, perform risk scoring, and orchestrate the entire approval workflow with compliance guardrails that are baked in. We are seeing them being able to develop a 360 view of physicians' behavioral patterns and preferences and orchestrate actions on behalf of the rep. And with all of this, the industry is just getting started because all of these examples are driven by single agent deployment. Imagine what would happen when we have the scale of agentic systems that foster multi-agent collaboration and coordination.
Yes. So if we go into the machinery, these AI agents are actually built on foundation models. Mathilda, how do you envision agents built on these models that can change the clinical research and personalized medicine?
So first of all, the current models that these agents are being built on are large language models, which means they have scoured the internet and publications and all the written and understood knowledge in history today and come up with the best answer that we as the human race so far has discovered. What we need to do is fundamentally raise the ground truth understanding of biology using AI. And that's what Bioptimus is doing by, instead of feeding language and text, we're feeding these models biological data. So that's, for example, cells, images of tumors, proteins, DNA. All of the different languages, effectively, of biology are needed in order to start to make connections that we haven't been capable of making as a human race so far. That needs to be the foundation on which these agents are getting their ground truth, not assumptions or predictions made potentially in some publications which might have had 2 patients or 5 patients in their studies. Now you can take thousands or potentially millions of patients and be able to make a judgments based on that. And what we've seen today, we have our models, you may not have heard of us, but our models have been downloaded 1 million times already. They've been used from a huge range of purposes. So we already have people using these models for biomarker discovery. That means discovering new cures for diseases. We already have models, people using the models for that. We also already have people using it for what's called pathology workflows. So when you take a biopsy, potentially of a tumor in your tissue, you currently have a person looking at that image in a microscope and then making annotations to say what they think the predictions of that patient's diagnosis are, what may happen in the future. Now you can use AI to dramatically speed up that pathologist's work, help them become more accurate, and then lead to better outcomes. But we've also been working with MIT, who have also been using it to understand and tell patients what the likely progression of their tumor is going to be before it happens, which helps the clinician themselves give better treatment and diagnosis. And it also helps then the patient ultimately feel better faster. So there's enormous amount of applications, but of course it needs to be built on the right ground truth.
Yeah, so it needs to be built on the right ground truth. This requires data, this requires computation power. So Arafat, a question for a cloud provider. What about the responsibility you have as a cloud provider to ensure AI agents will remain transparent, reliable, and interoperable?
Thank you. So life sciences is a highly regulated industry. So most insights require explainability, traceability, and reproducibility, especially when it comes to commercial operations and clinical development. And that, in turn, requires reliable, secure, production-grade infrastructure for AI agent deployment, whether it's memory, whether it's fit-for-purpose compute, long runtime, isolated sessions, and that's essentially what AWS provides. The second dimension to this is the scalability and interoperability of AI agents deployments. And AWS is committed on that front by supporting open standards. For instance, we are partnering with Anthropic on model context protocol, and we are constantly evaluating other open agent interoperability protocols that might be relevant.
Thank you. So, Jan, as someone who is leading hospitals, what, from an operational and clinical governance perspective, what condition must be put in place for example, your NHS trust to adopt these agents?
So this is a key question. And I have a provocative view, see what the audience thinks, that at the moment we have a very skewed risk appetite. Adoption at the moment of much of innovation, particularly including AI and agentic AI, I believe is overweighted on risk versus the status quo, which is seen as a risk-free environment. Whereas all of us know that the status quo is in fact high risk, particularly because of the demand-supply mismatch. And if you look at the evidence at the moment, certainly in the OECD data, there's a fantastic paper from the Copenhagen office on health experiences particularly across Europe. Actually, we're not doing very well at the moment. So the current system is not really delivering the outcomes and the experience that the public that we serve deserve. And so I think we have a risk appetite discussion to have. And I think the second thing is we're tending to think at the moment around deployment in hospitals. About 80% of current AI deployments are particularly machine learning enhancements in radiology, for example. But really the complex world is out of hospitals. It's in population health. So I think a challenge for us is what tools can we use to deal with complexity? And really, I think the scale and the capabilities of artificial intelligence can approach complexity in people's lives. And I think our task as a community is to try and find ways to articulate the risk of the current state, responsibly deploy into the future state, but particularly to think about how we're going to make a difference in the risk profile in populations.
Thank you, Emma. Well, for clinical trials and clinical developments, it's also very important. Adoption has to be done very quickly. What can you tell us about the emerging and leveraging clinical development with AI agents?
Yeah, AI is already part of the R&D and clinical development, and I think Mathilda and Arafat, they were talking about that, right? So in BMS, we are dedicated to R&D, and for example, in Europe, we are partnering with 125 hospitals doing clinical trial in multiple patients. Like we have about 20,000 patients enrolled in clinical trial. 5,000 sites across Europe doing clinical trial with us. So, of course, we want to focus on predictability and speed and the quality of the analysis. And we are already using AI agent to, as it was said, to predict among small molecule development but large molecule development which one would be the lead candidate to move forward. So this is really important. The second thing is we do, with the amount of data generated by clinical trial, we need also some tools to accelerate the analysis and the quality of the analysis. So this machine learning and these tools will really save a lot of time for us and deliver and help us to deliver quality analysis. And lastly, for real-world data, as you know, we are also collecting data once the treatment are available for patient, and we are constantly using real-world data to continue the research on our medication. So I think it has already kind of revolutionized the way we do R&D, and it will continue because, as you know, it's a journey, and the more we go and the more we learn and the more we get more, predictability and quality.
So it seems that everything is almost done, but Emma, well, there's still several technical breakthroughs that we still have to go through. What are they still needed for agent to handle truly complex multimodal data?
I would say even before technical, what we need is high volumes of high quality data. Biology is inherently multimodal and multi-scale. Each of your cells is interacting across thousands of different environmental triggers as we are sitting here today, making you feel something, making you react in some ways. And that's built up on lots of modalities. Now, science throughout history has tried to simplify down biology for the right reasons in silos, in proteins. Someone can spend 20 years studying one protein and what it can do. Whereas biology is inherently multimodal. So what we need to do, I mean, that translates also into hospitals, right? So, for example, my mother was sick with cancer, ended up in the heart ward because something happened with her heart, but it had nothing to do with her heart. And then no one in that ward knew how to treat the issue with her lungs. So, everything sort of the silos have trickled into how we treat patients. So what we're trying to do, and from a breakthrough perspective, one of the big breakthroughs has to be unlocking high volumes of multimodal data. We need to be able to track what each patient is doing across lots of different factors so that we can start to make connections that you can't make if you're only thinking in silos. That's the first thing. That's even before technology. But there's a huge number of technological breakthroughs happening when it comes to data capture right now that really are enabling this potential revolution in biology as we speak. Then there's something called the bitter lesson in machine learning, which is actually that there's a question whether you need to be smart and design the best algorithms, or whether you can just throw a lot of compute at something and which one will come up with the best answer. The bitter lesson is that actually throwing more compute at a dumber mathematic algorithm will actually come up with the same or a better answer than spending lots of time coming up with a better algorithm. Now that equation isn't really proving to be true in biology. We are having to develop proprietary new algorithms to start to make connections between different biological scales.
Thank you. Well, I would have one question for all of you. So the first one who wants to answer, feel free. So in your view, what is the most transformative role of these AI agents in the next 5 to 10 years that will really improve patient/citizen, because you were talking about prevention and all that, and their outcome? So.
Thanks very much. Excuse me, Stephanie. I think that question of superabundance is interesting. And as the compute cost comes down, we will have the ability to contact and potentially intervene with many, many people each day. So at the moment, the high-risk population is about 10% of any single population. They consume about 30% of healthcare resources. What if we could ring, using agentic, that patient every day and check in on them? Ask them about the tablets they've had. Have they had something to eat? Has someone nailed down the loose pieces of carpet that they tripped over last week? But to do it every day. Now, you can't ring 10% of a population using human intelligence, but you can using superabundant agentic. And I think that's probably going to be one of the biggest transformational changes.
Who else? Mema?
I think in severe life-threatening pathology, there is such a high unmet medical need, and I believe AI can really help discovery, R&D to accelerate breakthrough treatment and make sure that we are playing a big role in this race against time. Because at the end of the day, we need to bring those breakthrough treatment to patients faster to augment the survival, but to augment the quality of life, and to make sure that we really focus on those pathologies that are very hard to treat and complex to treat. So I'm a strong believer that AI will enable and support us to achieve this.
Thank you. Mathilda?
This is fascinating. I guess I've not been on a panel that has such rich depth and diversity in opinions, because I actually can't agree more. In my first company, when we were serving 6 million people in Africa and Asia and Latin America, the most tricky thing was adherence. So 30% had diabetes or hypertension, and they could be solved and really live a healthy life if they just took the right medicines at the right time. So huge kind of tick to what Ian has said. That doesn't have anything to do with foundation models. You don't need very, very complicated or expensive tools for that. So entrepreneurs in the room, please come up with some models for that. Emma has also said, I see a future where we have cures for cancers. There's not just one cure for cancer because there is an infinite number of cancers, but that we have cures. And this becomes a thing of the past. So it's such an interesting and fascinating space we're living in right now.
In one sentence, I would say it's AI agents orchestrating patient connection with the best physician or the right trial. So if I have to expand on that, like today, whenever we face a health problem, we start by looking for the first physician, typically in our comfort zone, in the area we live. And it takes the referral network months, depending on the severity of the disease, to get us to the right physician to treat our condition. I see a world in the future where AI agents understand the entire patient history and is able from the get-go to orchestrate the connection of the patient with the best physician that is able to treat their condition and that is best suited for their need, thus accelerating the treatment pathway quite substantially. And that same logic applies to clinical trials. We need to have AI agents that connect data sources, that break down compliantly data silos, and that are able to connect the patient with the right clinical trial, thus accelerating recruitment timelines and enabling patients to have access to life-saving therapies.
True. Okay. Next question for all of you. What would be for you the next step we will have to do all together to reach that state? Who wants to start?
Well, thank you very much, Stephanie. I think coming back to Mathilda's question on large curated data sources. So one of the things that I'm doing in London at the moment with colleagues and with the public is putting together a large data source, a secure data environment for about 10 to 12 million longitudinal records. But that requires a lot of deliberative work with the public. Certainly the public in London, through that work over the last few years, has said that they expect their health data to be used to make a difference for them or people like them today, to make a difference for people like them tomorrow, and importantly, to really help people like them in the future, which is the research question. But I think we need to maintain and ensure we are having those deliberative discussions now, because we don't have a lot of time left in the current delivery model. So my question, I think, and it may be for the audience to think about, is how are we going to make sure that we curate and create these large data sources that represent real-world patients, that we can then get new insights using the foundational models. And I think that is almost as big a question for us as the technology itself.
Can I follow up here? I mean, we should talk afterwards. No, because this is so fundamental, and this is a call to action to Europe, because Europe probably has the strongest regulation when it comes to patient data, for good reason, but also that is potentially going to create a barrier to Europe creating a foundation model based on European principles and European DNA, because you have very different rules in the US, in potentially some of the emerging world, and even in China, right, where these models are being built. So we really have to, as Europe, find a way that we can be comfortable with to unlock multimodal data in huge volumes to help us to understand and create these benefits for patients short-term and long-term.
I believe we need to find a way to orchestrate care across institutions and across boundaries. We need to find a way to get to AI agents that understand the entire patient pathway. And that means having electronic medical records that cover the entire health ecosystem. And the enabler behind that is having institutions that are able to organize their own data in a findable, accessible, interoperable, and reusable way, and serve it, or at least serve part of it, the part they are comfortable sharing as a product, to other relevant third parties in a safe and secure way.
I will echo what Mathilda said. We need to have in Europe an ecosystem that is supported by policymaker and government, and have some very strong framework that are enabling exploration, innovation, adaptive AI, autonomous AI. And so it's important not to be blocked, and it's not to be lagging behind what others are doing in the US or in China. So that's one thing. The second thing for me is experimentation. So we need to really stimulate the medical community, healthcare system to experiment. If it's falling, if it's failing, that's okay, we learn from it. If it's good, we scale up and we move to a bigger reach for patients and for the healthcare system.
Thank you. One last very quick question. We didn't talk much about who we have to acculturate or at least train, if we want. Who do you think we have to focus on? I'm a professor, I'm in a university, we are training our future medical doctors. What about the other person?
Well, I think we certainly have to have a different approach to education at the moment. We're tending, and this is true certainly across Europe and partially in the US, to train certainly in medicine for a historical model. And we need to make sure that university curricula are fully conversant with these types of conversations. And also for the rest of the workforce, both clinical and managerial. The world is going to be very different, I think, in 10 years. And we need to start today to give those skills to the people who will certainly come after me, those skills to work with these new worlds, and also to work with complexity and occasionally ambiguity. Health systems are not used to working with ambiguity, but we need to encourage curiosity.
Sure. Someone else wants to. What about training in pharma industry? Do you?
Yeah, I think we are partnering obviously with researchers, but with physicians, also with nurses, also with patient association, because there are many complex disease and treatment where the patient needs to be supported. And so we have developed many agent, AI agent app like AI nurse, but also patient companion that can keep on training and educating the patient according to his needs. So yeah, this is ongoing, and we are all in it. So I think we are all learning, and this is the beginning of the journey.
I think we've covered, right, the researchers and professors, of course, that they'll be at the forefront of this no matter what. Clinicians need a lot of probably training to understand this and confidence to use it. And that will take some time with interpretability and explainability of these models. And then you have patients as well, of course, as you said. I think we're in a moment in time where now patients are going to be able to start taking, you all in the room, us, taking control of our own health and our own healthcare journeys through systems. And finally, I think we should bring regulators and governments along as well. Why leave them behind?
Great, thank you. So, for regulators in the room, we are ready to train you. So thank you all for your insights, and a deep thank for our panelists. It's clear that AI agents will really have a tremendous impact in the following years, and we need to go and collaborate all together to make it happen, both in terms of data, in terms of computational power, in terms of clinical knowledge and mathematical knowledge as well. So thank you all